discussing is heart rate modification in clinical practice. In clinical practice, we are dealing with simple stress anxiety patients are having probably heart attack and multiple series. So friends, a heart rate modification is not only tachyarrhythmia. It should be considered as tachycardia and bradycardia. Although we are getting more and more patients related to the practice of tachycardia. If you see the causes of increased heart rate start from the very early part of disease and the most common stress, anxiety and that which are included in the psychiatrist practice and or psychiatrist tendency. Emotional stress, anxiety, some day-to-day variation, their sexual variation, so many things is there. So now I'm not touching with the stress and anxiety part of this tachycardia and bradycardia. I'm touching only pathological causes of tachycardia and bradycardia. Just very one simple example. Just before I was coming here, sir was talking related to one patient, and she was having I'm giving the example for the same case, sir. She was having mitral stenosis, sir was telling on the phone, and somebody gave him IV fluid, and patient had a CHF and a tachycardia. Just I listened on the phone. So even 20-year-old female came to us in the clinic and she just complaining of having tachycardia, don't mention out to your side. Let us think for this organic process of that why she is having mitral stenosis. Very obese female, 20-30 years having might possibility of pulmonary embolism. Simple presentation is sinus tachycardia, splitting and diaphoresis. So discussing on this how to CAD is the important part of morbidity and mortality. So if we optimize the heart rate and what the reason behind it, what is the thought process? We know from the physiologic process systole and diastole. If there is tachycardia, diastolic timing is reduced. So ultimately coronary feeding is compromised, and if it is compromised, then end diastolic pressure is increased. Further there is decrease in organ filling, and this ultimately lead to some complication in terms of frank ischemia, episodic ischemia, or bursting of ischemic disease or bursting of heart failure. That's why optimization, I am telling optimization, not extreme reduction. Optimization of heart rate is very important. So, myocardial ischemia may be provoked just by tachycardia by reduction of this coronary supply, and this is especially effective when patient is having microvascular dysfunction. I will come with subsequent slides. And this is some natural history of coronary artery disease. Patient is having remodeling, hypertrophy, clot formation, and in the kidney albuminuria. So what is the relation with the heart disease? Suppose my patient started with the LV hypertrophy, like the remodeling is there. There is status and problem with the concentric hypertrophy of hypertrophy. On one aspect of disease, one patient is having heart rate of 70 and one is having heart rate of 110. So if the remodeling and hypertrophy is going until unless you are not optimized the heart rate, subsequently you are reducing the coronary supply and especially microvascular circulation in the hampered interference to major frank epicardial coronary arteries. So this is some cascade of action on all these comorbid diabetes, hypertension, obesity, advancing age, atherosclerotic process. Important for heart rate is because the atrial ectopic and trigger activity of SNR and strain in this atrium. It starts as ectopic rhythm and either in the form of sinus tachycardia, atrial ectopic, or prime recurrent of atrial fibrillation.